Hello and welcome to the Healthcare Leadership in Action podcast from the Faculty of Medical Leadership and Management. My name is Judy McKimm. I'm Pro-Dean and Professor of Medical Education at Chester Medical School, Professor Emeritus of Medical Education at Swansea University Medical School and Associate at FMLN. This second series is focused on postgraduate leadership development and assessment. It is sponsored by the Dinwoodie Charitable Company as part of a project to improve leadership development and assessment for doctors in training. So welcome everybody to our latest podcast. We're going to be talking about the role of assessment of leadership skills and behaviours. It's a very challenging area to look at, and so I've got one of my colleagues and friends, Dr. Jo Lipton here, who's a consultant anaesthetist from Guy's and Thomas's Foundation Trust in London. And we've been working together along with FMLN for many years on a number of projects. But today we're going to talk about some work that Jo has been doing in two areas. The first area is that he's been looking at entrustable professional activities as a form of assessment with the Royal College of Anaesthetists. So EPAs are used widely in postgraduate medical education primarily. These were developed in the Netherlands, in the US and Canada, and they are a form of framework in medical education where our doctors in training are evaluated on their ability to perform certain critical tasks without direct supervision. In other words, it's all about defining the activities that should be able to be done ultimately without supervision, that you would trust somebody to do, and then assessing your learner against these. The difference between EPAs and other assessment is that it's very tailored to individuals and their own capabilities and their progress. So it is a little bit more nuanced than expecting everybody to be able to do exactly the same thing. It allows you to identify some remediation that might be needed, as well as when learners can safely be left alone to do tasks. So it is a different way of looking at assessment. So I think the first thing, Jo, it'd be really interesting to hear from you about your project with the Royal College of Anaesthetists. Just tell us how it began and what you've done so far. Thank you.
Yes, thanks a lot, Judy. Yes, a really good summary of what EPAs are and what they're for. The way that I got involved was actually while I was still in training myself. And I was working in a department where there was a learner that was doing the very first phase of anaesthesia training, which has a milestone called the initial assessment of competence. We had a curriculum that was implemented in 2010, and it was one of the earlier iterations of what might be called a competency-based medical education curriculum. And the way that worked was that all of the activities of the profession, if you like, had been divided up into very long lists of competencies. And within this first milestone, that IAC, the initial assessment of competence, there were actually 19 individual competencies, and each of those was being assessed using an individual workplace-based assessment of one or other flavour, so be it a DOPS for a procedural skill or a case-based discussion for something that was covering a knowledge element. And every trainee in the UK would go through that exact same series of hurdles to be awarded their IAC. And what that meant was that the aims and objectives, if you like, of that phase of training were really clear. And there was a nice long list of boxes to tick to be able to progress. But what sometimes happened, and what I observed firsthand, was that it could be possible to do each of those individual assessment components in isolation, but for there to be something important that was lacking about that person's overall capability to be trusted to do the job that was expected of them after that period of time. So what happens in anaesthesia training is that IAC as a milestone is a kind of point after which you can be put on an on-call rota. And that means that you're trusted effectively to provide general anaesthesia for straightforward patients having low complexity surgery outside of normal working hours. And it's used as a quite important marker of transition. What happened in that particular context some years ago now, like nearly a decade ago, I think, was that that particular person collected all of the evidence that was required, but there were underlying concerns about that person's capability. They were allowed to progress, and then quite soon after progressing, there was an adverse incident. The person was taken off that on-call rota, and it was really traumatic for that person in particular. And I just felt like there was a big problem there, and that we were doing the wrong thing in the way that we were conceptualizing how to assess people's capability. So that was the background. And what followed after that was a lot of research that I was doing, reading around in the educational literature as to how this vexed issue of trying to pin down someone's workplace competence or capability could be captured and evidenced. And EPAs was what was being delivered in, as you said, in other contexts, in the Netherlands, in North America in particular. And so what we did was to look at that initial assessment of competence phase, or that first 3 to 6 months of anesthesia training. And instead of atomizing the work into a long list of competencies, we instead defined 2 core entrustable professional activities that were a better marker for what the expectations of the workplace were. And so we instead now have 2 EPAs for our IAC. One is performing an anesthetic preoperative assessment, and the other is providing general anesthesia for a straightforward ASA 1 or 2 patient. So that's somebody who with low burden of comorbidity, who's having a kind of straightforward operation. And we've got an assessment strategy that then complements that, so that you build up a portfolio of evidence in each of those 2 EPAs. And then there's a faculty judgment around readiness to progress. And it has that component that you mentioned of defining how much supervision does the person need for a particular task, and then having a body of evidence to make a kind of grounded decision as to whether the person's ready to progress. So it's supposed to be more personalized, more nuanced, and a better reflection of what those expectations of the workplace really are.
Thank you. That's really good, isn't it? How you work that out. And I think you're right. I think competency checklists can actually turn into that. Somebody can be technically really competent, but you wouldn't trust them to do something. And it's how do we evidence that, and what is that? And of course, I think what we've tended to do, certainly at undergraduate level, which is where I work, we tend to look at we don't tend to look at competence, but we tend to be notching things off, and then we wrap everything up under a professional behaviours umbrella. And of course, then we start ending up, if we're not careful, on fitness to practice and all that sort of thing. But it is all wrapped together. But the trustworthiness is slightly different approach, isn't it? From thinking about, do they show respect, or, are they a good team worker? Actually being trusted to do something feels like a little bit of a subjective judgment. But actually, if you're getting that trustworthy, if a lot of people think you're trustworthy, you probably are. And that's, so it's getting that multi-source sort of feedback. So you just tell me how the judgment part works, about how does somebody get ticked off as being trustworthy? It can't just be one person, can it, at all? It has to be, multiple.
No, you're quite right. And I think that is at the heart of what is still challenging and contended in the field of competency-based medical education. But you're also right to say that defining the expectations in a different way, and embedding that nuanced judgment that has really always been in place, especially in the apprenticeship model of learning that we have in medical training generally, and really specifically in anesthesia. There is something quite special in that judgment that takes place in the mind of the supervisor as to where do I need to be while this activity is taking place. Do I really need to be in the room? Can I actually be in the coffee room? This is quite an anesthesia kind of descriptor, but this is the way that we operate. Or could I be at home? And then trying to encourage our supervisors to surface what it is that informs that judgment. The way that we do it in our program is that we use a portfolio of supervised learning events. So we still use the same tools that were always in place. We still will utilize, DOPS is a good way of drawing out the learning points from a procedural skill, and a case-based discussion is still a great way to interrogate like ways of thinking, and looking at a case kind of in its entirety. Where it's different from where we started from is that we've built in a great deal more flexibility for our learners to build a portfolio that reflects their own progression. And we encourage them to basically conduct these low stakes assessments really regularly. and to capture the conversations that are taking place in the workplace. What a good example for me is that if I do something with a learner today and we have a conversation about it, then what takes place is that I've observed them doing something. We've then had an in-depth discussion about what's taken place. They then tend to go away and write a reflection that is embedded within an online form. And when they do that, I then see what they've taken from the conversation. I can see what they think is relevant and what they plan to do in the future. And when you take several of those over a period of time, you can really see progression. And I think that when you instead have a much more rigid model like we used to have, that type of progression just isn't really captured. When you then sit as a faculty of trainers, all of whom have worked with that individual regularly, and that's really the ideal, is that you're trying to get a faculty of trainers that observe that progression and have that evidence there in front of them in the portfolio, and you can map it against what the expectations are as they've been set in the curriculum. You then have this ability to make these personalized judgments about whether somebody's ready and have a decent body of evidence to support it. You're right to say it has to be more than one person. In our curriculum, we've got a variety of tools in addition to those supervised learning events. We use something called a multiple trainer report tool when we're really trying to make that critical progression point judgments. And it then collects feedback across a range of domains, not only the clinical ones, but also some of the more generic professional domains that we might talk about later. But informing that entrustment decision, we're relating all of those pieces of information to the expectations that are set out in the program, and that's intended to be more robust than what we had before.
I think you're absolutely right, and I suppose what it reflects is as you mentioned at the beginning, that international trend went in assessment in medical education and other health professions, where we really look at a much more programmatic approach to assessment with multiple data points, lower stakes, and actually the judgments are made, by a panel or the weight of the evidence. And of course, if you've got these multiple data points and this evidence, it's actually really useful for people who aren't trustworthy or untrustable or who aren't ready to progress, because you've got the evidence before you. So the vast majority of people will sail through just quite normally. Some will be way fantastic, and then some will not, and you want to be able to manage all those people. So I do think it fits with, I do think this approach, and it was really interesting when I heard about the college work, because I do a lot of work on professionalism assessment in the undergraduate sphere, and I think this is all, it's all part of the same piece of work, isn't it? So I think
you're right, and it's what's difficult. I'm sorry to speak over you, Judy, but what I think is interesting is that, and where there's work to be done, I think, is in trying to help people to come up with the language to articulate that trust decision. Because sometimes we're so used to forming these judgments implicitly that it can be challenging to put some kind of useful terminology or language that justifies decision making, but also can be developmental to a learner. There's some really good stuff so Olive Tenkart, his group who devised EPAs in the first place, have written some really interesting stuff about what are the building blocks of that entrustment decision. And they've come up with this useful mnemonic, which is called making a rich entrustment decision. So so the A stands for agency, like is the learner showing evidence of taking responsibility for their work. Then there's R, which is reliability. There's I, which is integrity. There's C, which is capability. And then there's H, which is humility. And I find that framework really useful because it really broadens your thinking around what is informing my implicit judgment about where I position myself on this day, or at a higher stakes level, like what do I trust this person to do in the future? Because that's what you're doing, really, isn't it? You're making a prediction about the future. And I find that mnemonic to be a really helpful way to look broadly and then to start to drill into, okay, like, well, the thing that really bothers me about this learner is that I don't think they're necessarily showing enough humility. I don't think they're showing that they understand that this could go wrong in this particular way, and this is where they need to mitigate, for example. Or perhaps they're just not taking quite enough responsibility for their own learning, and I need to really direct them more in that space. So I find that to be really helpful, and I think that's where we need to be going in terms of helping our trainers to be thinking in that way. because these judgments are very often implicit. And I know that you've talked about differential attainment, and I think that's the danger zone, is if we don't really think carefully about how to make those judgments and make them fairly, then all of our intrinsic and implicit biases will just be manifest in this space in the same way that we know that they are in others. And that's important.
Yeah, I absolutely agree with you. And I think that's the whole of the, multiple raters, multiple contexts, multiple times, isn't it? That's the more you get towards as an objective judgment, as opposed to you've got multiple subjectives equals an objective is always what I think.
Collective subjective.
Exactly, the collective voice. And also from a trainer or from an organizational perspective, we're much better. It's much more defensible as well with that, because it doesn't just simply, as you say, in the olden days, rely on a single assessor or something like that.
Mm-hmm.
So we could use EPAs in leadership and management assessment, couldn't we? And I think, you and I tussled this around quite a lot in the past, haven't we? About thinking, how do we actually get people to be identifying opportunities where leadership and management is happening? How do we get people to start reflecting on that? How do we, as trainers or supervisors, but also as doctors in training, how do we seek those opportunities out? So I think one of the things, certainly I think the General Medical Council's professional capabilities framework has actually been very useful, and we've seen leadership management being strengthened in all the General Medical Council's guidance over the years, including in outcomes for graduates. But do you want to tell us a little bit about the work that you've been doing in the Learning Hub, and how you've been working with doctors in training using the professional capabilities framework, but perhaps with that specific focus on the leadership and management development, and just some of your learning from that and what you've done, I think would be really nice to hear.
Yeah, I'd love to. For context again, and this relates back to the stuff that I do or have been doing through the Royal College. Obviously, the generic professional capabilities framework is now baked into all postgraduate medical curricula. For us in anaesthesia, it represents half of the 14 domains of learning that our curriculum is comprised of. And what's been important about that is that although many of those kinds of non-clinical activities were certainly being done by learners in anaesthesia for years, these are things like quality improvement, research, education, patient safety initiatives. They were kind of hidden in our old curriculum. They were a back page feature of your CV. They were things that you had to do to get a job, but they weren't necessarily really viewed as core to your development as a professional. And I think that the GPC's domains of our curriculum, the GPC's framework, has put a much more appropriate focus on the fact that this is a really core part of what every doctor is about. And what that meant for me on the ground is that I was looking at my department, I was looking at the opportunities that were available for trainees or for people working towards curricular objectives, and seeing that it was not the most organized of offerings. You had to be in the kind of right place, right time to pick up a good project. It was often something that you were trying to really squeeze into that short time frame that you had in a rotational training program, six or 12 months or so. And it seemed like a big missed opportunity for us to try to get our learners more embedded in what was going on in our department. And so we set up a framework that was intended to try to signpost those opportunities more effectively, and really importantly, devise some new roles for trainees to participate in, so that they weren't just picking up quick win projects to satisfy the box ticking on their ARCP, but instead they were getting something meaty and substantial, and they were able then to develop their leadership and management capabilities within those roles. Because I think that's what I felt, was that actually it's the workplace experiential learning opportunities that were lacking. And that meant that people were not necessarily getting those developmental opportunities from the projects that they were picking up just to satisfy the bare minimum requirements of training.
No, that's really, I think that work is so important, isn't it? That we have some sort of structure and some training. And I think a lot of it starts with the trainers or the supervisors themselves actually thinking about we've talked about before, making the implicit explicit, or making the routine something that is different. It's a bit like with patients, isn't it? We think, they're coming into hospital, oh, we've seen this 100,000 times, it's routine for us, but for that patient, it isn't. And so for, a doctor in training coming, say, to a multidisciplinary team meeting, or, attending perhaps a senior executive meeting, or doing the rota for the first time, this is a new experience for them, and actually we've got to learn all these things, and we just routinize things as we become more expert. And it's very much, I think, like unpacking clinical skills. You've got to remember when you first started how you had to be explained, that you reflected, you thought about it. So using tools like purposeful observation, a lot of the things we use in teaching and learning, can be really helpful. So to train, it's like, I'm going to chair the MDT today. Just watch how people, observe, and give me some feedback afterwards about how you think I chaired, and did I include everybody. Actually, sometimes putting yourself on the spot can be really useful, can't it? About saying, let's have that conversation. Could I have done things better? That's reflective for ourselves. You've got to be in a good place to be able to do that, haven't you? But
you're
but
right, you do.
Yeah.
I think probably there's a couple of things that come up for me on that subject. That one is that you're absolutely right. I don't necessarily think that most of us in our non-clinical roles are necessarily thinking in the same self-critical ways that we do in our clinical practice, and perhaps we don't have such a clear vision of what good looks like. Even it mightn't be that many people, in being a team leader, or in being in leading a project, or in some of the their other leadership roles that they might inhabit, I personally wonder whether it takes a bit longer to try to develop some kind of confidence in that space, particularly as somebody who's a relatively, I'm in my first 5 years of being a consultant, and I suspect that I'm not alone in feeling that my non-clinical roles are the ones where I've got the most to learn, because so much of my training was focused on becoming a good clinician. And I think that that's what's quite interesting and challenging, is that we've got a cohort of trainers here who didn't really have the focus that our current crop are having on their broader professional development. And yet they're in positions of mentorship, trying to guide and bring forward people to have a broad sense of their own professionalism. And I think that that's a challenge. So, there's work to be done on both sides. And one of the big things that you're totally right to highlight is surfacing in our own attention when we are undertaking a leadership activity, and the fact that that's very pluralistic. Actually, we're quite used to thinking of our leadership behaviors in a clinical context, where you're that person at the end of the bed directing the cardiac arrest. That's kind of like the archetypal leadership role that most doctors would go to. And actually, when you zoom out from that and you see that, wow, we perform leadership functions in so many other varied contexts, and we also flex our leadership practices to the situation very often. And you do then, when you open your mind to it, you spot it being done brilliantly in some places, being done less well in others. And it's as soon as you start to form those judgments that you can realize that actually there's so much substrate for reflection and conversation there that we're not really having. And getting into the habit of having those debrief type discussions in the same way that we would after a clinical encounter, as when you've had a meeting that's just gone terribly, like, oh, what happened there? Where did we go awry? Or what was it that I said that perhaps put that person off? Or how did that stakeholder respond to that little thing that I just said there? Those are the sorts of conversations that I think are much rarer, but are so fruitful. And it probably only comes around when we focus our own attention on the fact that that's really what we're doing.
No, I think you're absolutely right. And I think that what you said earlier about, our biases, or, it's exactly the same as when we start to surface some of our cognitive bias, isn't it? We start to be aware that we automatically think of this sort of person in that box, and we shouldn't. So it's just raising awareness of things. It's having the right language to use as well. Actually using the words leadership and management. Oh, could you lead the ward round today? You lead the ward round, I'll follow, is actually really putting that in. It's just very small semantic shift, but I do think it makes the shift. But just to bring this sort of to a close, I suppose, what about if we're thinking about the entrustable professional activities, I think that they could be really useful in that space. Would I trust you, Joe, to lead a ward round? Would I trust you to be left alone, if with on call with if something dire came in? Would I trust you to be able to manage it if you could? And would I trust you to give me a call and bring me in or ask for my advice if you were struggling? And so in a leadership perspective, if we think about the things that we are expected to manage and lead, do I trust you to do the rota properly, or do I have to double check it and change it, or do I just do it myself because I don't trust you at all? And just sometimes thinking about it like that will help us put that frame around it. So I don't know what you think about that, but to me, it feels like another mechanism we could use, actually.
I think it would be a really valuable exercise to try to articulate what those EPAs would be, because it's to do with having a kind of critical eye on what are the workplace activities that are core to a profession. And it's quite easy to do in the clinical space. And many of those clinical EPAs will clearly have, particularly the more senior you become, a leadership component, where I think it's interesting and really worthwhile to do some work in this area would be to think about them in some of the more non-clinical aspects of practice, and to see how the leadership components might be manifest there. I think that building a portfolio that is a leadership-based portfolio across clinical and non-clinical areas of practice would easily map to an EPA type of framework. I think the thing that is most important for me about utilizing EPAs is that they're a faithful representation of what exists in the workplace. And so that's why I think some of the stuff that I'm doing around trying to enhance roles and create opportunities for people is sort of like the foregrounding that would need to happen, because it would be wrong to define EPAs that are great in theory, but which are difficult to action in the workplace, because the trainees and learners are not empowered to inhabit those spaces and don't really have the opportunities to develop entrustment potential or entrustability, if you like, in some of those things. So I do think it would be a great place to be exploring and to be starting to kind of think about how you'd configure some EPAs in that space. And I wonder whether they'd be applicable probably to all postgraduate settings to a greater extent than the clinical ones, because that is where much of the overlap does exist between specialties. And I think that's quite a helpful way to think about generic professional capabilities. Yeah.
Yeah, and that reminds me, I know we're coming towards the end of our time, but that reminds me of when we through the Dinwoody project, I interviewed a lot of experts. In fact, I interviewed you. You were apparently an expert, Joseph. So good about your Royal College work, and that was a few years ago. But actually, one of the experts, I think somebody from Canada, an emergency medicine physician, was actually saying, the expectation of their senior trainees is to actually manage the room, manage the department, and they trust them to do that, and they observe them, and then gradually they become that supervision or observation becomes more indirect and gradually remote, and then eventually they can do it themselves, and they're on the rota. And I just think those sort of things, I think the link between EPAs and supervision, as you said it, didn't you? Do I have to be standing next to the person? Can I be in the next room, whether it's a coffee room or another room? Can I be at home? Do I have to be there at all? They're the steps in supervision we often talk about. And so thinking about, can I trust somebody to chair it? I always think with my team at work, do I trust them to chair that meeting without me? Yeah, of course I do. I trust them that they'll do it properly. I trust them to tell me if it's gone belly up, so if I have to rescue. But I also trust that they'll tell me what's gone on and tell me what I need to do. So I don't have to be there. And that's a really, for me in a sort of in an educational leadership role, that's really useful, because you can't be at every meeting. So you gradually have to develop your team so they can actually do things without you, and do tasks, and you gradually learn to know who can be trusted to do things. So I think it fits really well with your sort of general life.
I
So
think you're
let's.
right, and I think that I'll just say one final thing, which is that
Yes, I was going to ask you to say a final thing.
oh well, actually, I'll respond to what you
Say
were
a
going to say,
final thing, and then a
but
final thing.
the job of defining what those tasks are, the things that you are expecting to hand over the reins for, they're so handy. It's such a useful framework, really,
Mm,
because it's just a shared attentional focus. Then there's nothing that's kind of unspoken. It's clear, like these are the tasks. And then when you do that, you then have to ask yourself critically, and the process of devising like the attendant assessment structure that goes with it is like, what are the components of good practice? What are the things that, and you've just said it yourself, like, can they do the things? And if they can't do the things, do they recognize they can't? And do they ask for the help in the appropriate way? And do they safeguard it properly? And all of that is quite complex, but can be broken down. And when it's broken down underneath the banner of something really clear, like an EPA, then that's like just a really good way to operationalize that trust process that takes place.
yeah.
So yeah, that's what I like about it, and I agree. It has great potential to be applied in a lot more settings than it currently is.
Absolutely, and I know we work with the GMC as well, and I think having a look at that professional capabilities framework and actually say, well, what could be what the entrustable bits of this, and you don't want to end up in a space where do I trust somebody to maintain eye contact with the patient? You know what I mean?
Exactly.
We don't get down to that nuances of checklist, but it goes right back to the global judgments that we are moving back to, because we know they come from that sort of fast thinking, the intuition part, and we there's a lot behind it. So I'd just like to ask you, and I'm going to let you have the near final word. What about, as always, what would be one bit of advice that you'd give to people about assessing leadership and management?
I think that probably the first thing that needs to be your focus, if you're somebody that devises programs or oversees education in a department setting, is, are there opportunities on offer for your learners to demonstrate leadership and management capabilities in a multiplicity of settings? Is it the case that they can only do that when they're on call and it's the middle of the night and nobody else is there? Or do you have structures in place to enable them to chair meetings, lead projects, take ownership of things in spaces that are across the board of their professional practice? And if you don't, like, what can you do to try to enhance those opportunities that are very much focused in the workplace? Because I think that, we all know that going off to a leadership development course towards the end of your training is not the way that you develop leadership capabilities. You really need to be practicing these things and having a space to reflect on them. So the first thing that you have to do is make sure that those opportunities exist in your context. And that's really what I'm trying to do with my GPC hub work.
That's absolutely, I mean, that fits so well with what our colleagues have talked about in some of the other podcasts, doesn't it? The role of vertical leadership, seeking opportunities, asking for feedback, as well as being able to give feedback, the role of reflection, the role of hearing other people's perspectives on things. It all fits really well together. And from an educational point of view, the whole idea about leadership and assessing any aspect of professional behaviour, because this is what we're talking about, on managerial behaviours, is actually thinking about, well, what tools do we use? How do we use the tools we already have, as you said, the SLEs, the DOCs, the Mini-Kecs, etc. How do we use those? But also then, are there some new things that we can actually think about? And I think EPAs are a really good example of that haven't been used so widely in the professional or the leadership sense. Mm-hmm. So I would like to just thank you very much for having the conversation with me. I hope those of people who listen find it useful, and I'd like to just say thank you very much, and let's close.
Thank you.
Thank you for listening to the Healthcare Leadership in Action podcast. If you want to learn more about what we do at the Faculty of Medical Leadership and Management, check out our website, www.fmlm.ac.uk, or follow us on social media, X at FMLM_UK, or you can find us on Facebook and LinkedIn. Thank you to the Dinwoody Charitable Company for sponsoring this project, and to our producer, Dr. Sharia Khan, and advisor, Dr. Ray Carlson. We'll see you on the next episode.